Healthcare spending is surging, and nowhere is this more apparent than in the pharmacy. Legacy PBMs have long promised to manage costs, and yet patients, employers, and pharmacies alike are paying the price. Today's guest says there's got to be a better way. Welcome to CareTalk Executive Features, a series where we spotlight innovative companies and leaders working to advance the healthcare field. I'm David Williams, president of Health Business Group. My guest today is Dr. Alan Pannier. He's Chief Strategy Officer at SmithRx, a modern PBM aiming to fix what's broken in the pharmacy benefits landscape. Alan, welcome to CareTalk.
Thanks, David. Happy to be here and excited to dive into the topic of pharmacy benefits.
Great. Well, drug costs have gotten a lot of attention, but they're continuing to go up despite decades of PBM management. So you have this pharmacy benefit management, and yet the costs continue to go up. Why is that?
Yeah, it's a great question. It seems like somewhat of an oxymoron, right? If the pharmacy benefit managers are truly managing your benefit, why do we continue to see healthcare costs go up and to the right, particularly in pharmacy? And really, to be honest, a lot of it starts with the fundamental kind of legacy infrastructure that exists today and the power of three large companies that we'll dive into and talk about that we like to call internally big health.
Okay, yeah, that's a good one. So, use this term legacy, and I'm wondering, why? I mean, they've been around and they've dominated, and costs have gone up. So why is it that what kind of role do they actually pharmacy benefit managers play in some ways accelerating costs rather than constraining it?
Yeah, I think the initial intent was really well-intentioned, right? You had employers that were providing benefits to their employees. And one of the most used aspects of employee benefits is pharmacy, right? Patients take medications to treat diseases that they have. And, the idea of a pharmacy benefit manager really came about in the 60s and 70s, but it was a technology play. It was, we've got patients that are employed by an employer that wants to provide benefits, and you have pharmacies that are providing medications. And there's not a good way for the pharmacy to facilitate payment between the employers, but even know that the employee is actually employed by the employer in this case. And so the idea was, hey, we can create a technology or a connection point between pharmacies and plan sponsors, which largely was employers. And the pharmacy benefit manager can serve as that middle layer, facilitating payments and data processing between the two entities. Unfortunately, over time, that's been somewhat manipulated as they've become kind of inserted themselves in the middle layer. And really, sadly, as I mentioned, we call it big health because you can't really say it's an insurer anymore because of the vertical integration that exists. I mean, you have these entities that own pharmacies, they own providers. There was a recent report that came out that said United Healthcare owns like over 10% of the providers across the country. And so you have plan sponsors, which are largely employers, providing dollars to these entities that they're trusting and negotiating on their behalf, but they're negotiating with entities that they own, whether it be a pharmacy or a provider, or even if we have time to dive into it, they've now started creating manufacturing processes for medications and are now drug manufacturers. And so you immediately think about, right, the misaligned incentives there. If I'm negotiating against myself with someone else's money, what are the incentives, right? Largely to increase costs and pay myself more. The challenges with, why that isn't so obvious really comes down to the black box that exists in that what we call kind of payer layer, which is the facilitation of these negotiated payments between these benefit managers and the parties that are providing services. Largely, it's taken historically what we call kind of a discount-based lens of focus, saying, oh, I'm getting you better and better discounts. But if it's a good discount off of a higher price scenario, you're actually not getting any better. And that's truly in the simplest form why we are where we are today. This kind of discount-based way of thinking.
I mean, you'd say it came out of like the old time. It was a technology play. So it was actually, some of these were mainframe computers, literally, that it was plugged into, which I think you still see there. And if I recall correctly, there was a time where the PBMs seemed very threatening to the pharma companies, and they started to buy them, including, Merck Medco for a while, right? And I think it was maybe another one, PCS was bought by one of the drug companies. So
Mhm.
Then they became independent for a while. Now they're mostly owned by health plans, and then they're sort of getting into like all these other spaces. What is it about it that got them to be so big and so dominant? I understand if they're in a dominant position, why they might tend to abuse it. That's kind of a natural law. But how did we get just big three, big health,
Yeah.
as you say?
Yeah, it's a great question. I think, it's fascinating to think about, like you mentioned, in the early 2000s, you had pharma companies that saw the power that these pharmacy benefit managers had and said, hey, if we own one of these guys, we can control the flow of our drugs, right? We can make sure that our drugs are being used, which obviously is its own kind of flawed with misaligned incentives. And the FTC and DOJ said that's not going to work. And so they shut it down. What's interesting is I think because it's such an unknown space, right? And healthcare is so complex and confusing, and the payer side of it is even more confusing, that it's fairly easy to sell to a lay person this idea that vertical integration is good, right? You could say, listen, we've got economies of scale, and if I own the pharmacy, then I can buy drugs at a really good discount, and then I can lower the cost for the employers. And it's true to some extent that they are, buying in bulk through the mail order pharmacy and lowering the cost to deliver these goods and services to patients. What's left out of those conversations is they were, talking up on the hill about, hey, this is okay, you should let these mergers go into play, is that those savings dollars weren't being passed through to the ultimate payer, right? They were presenting themselves as the payer, saying, hey, we're the payer and we're going to lower costs by going through this vertical integration. But sadly, the actual payer is plan sponsors, and they didn't have a voice in this equation, and largely still don't have a voice.
Got it. So at the end of the day, I mean, there's a lot of parts of the U.S. economy where there's some oligopolies or some other behaviors. This one may be particularly bad. But how does this then filter down? Like, who is hurt by this? You mentioned, there's the employers. You think the patients are in there somewhere. Part of this big health is also these big, pharmacy chains, some of which own insurance companies themselves, which are involved here. And whereas I think about independent pharmacies, used to be a few more of them around here, not as many. I'm in the Boston area. Who's impacted by this kind of big health and the PBM side specifically?
Yeah, it's really everyone you listed, right? I think, at the heart of it, the patient's lost, in that they have less great of an experience. They're also overpaying for healthcare. I think we've seen in the last 18 months several lawsuits where you now have employees suing their employers, large employers, for not doing their fiduciary duty, right? For choosing more expensive providers of pharmacy benefits. And they've slayed in these lawsuits many examples of, these are scenarios where you're covering a higher cost drug over a lower cost drug. And my out of pocket is hurt by this, and my premium is hurt by this because my premiums continue to go up. And so I think patients are at the forefront of being hurt by this. You mentioned pharmacies. I think independent pharmacies unfortunately are getting the brunt of this as well. And that piece, to not go too deep, pull me out if I start geeking out too much, but would love to just dive into that a little bit and talk through why why independent pharmacies are getting hurt.
Yeah.
The root of it really comes to this idea of this kind of discount based way of evaluating pharmacy benefit managers. So just to give you kind of a quick overview of how that selection process works for employers. So if I'm an employer, I provide benefits to my employees. I need to contract with a pharmacy benefit manager, and there's many out there to choose from, not just the big three that we're talking about today. Typically, the way that works is I will contract with a benefit consultant, because if I'm Home Depot, I'm really good at tools and hardware, but I don't really know a lot about pharmacy benefits. So I'm going to contract an expert. That expert is going to help me kind of put together my benefits, not just pharmacy, but medical, vision, dental, all the benefits that are provided to your employees. And as part of that evaluation process, typically what happens is that benefit consultant will go out to the market, select a handful of pharmacy benefit managers. They'll share historical claims experience. So, hey, these are all the prescriptions that have been run by the employees of Home Depot over the last year. Please tell us what your pricing would be in this scenario. And that's kind of the beginning of the financial evaluation process and how you pick a PBM. Unfortunately, the outcome of that analysis is largely focused again on AWP discounts, saying AWP, just for those that don't know, stands for average wholesale price. It's effectively the sticker price of a drug. They joke in the industry that it's the acronym is ain't what's paid, because it's not actually ever what's paid for the medication, but it's the starting point. And then typically a pharmacy benefit manager negotiates with pharmacies as kind of that starting point going down. So the way that the employer looks at it is they say, okay, on average across my millions of claims in the case of Home Depot, across all the pharmacies, what's the average pricing you're going to provide? And that's the first kind of flaw of the evaluation, is that in itself is just fraught with games in terms of how do you define a brand or a generic drug? And what about a drug that's for 40 days instead of 30 days? How does this get bucketed and everything else? And so that's the first problem of it. But why independent pharmacies get hurt and why this is important is, as a pharmacy benefit manager, SmithRx is no different than any others, right? We negotiate with pharmacies, and the larger pharmacy chains have more negotiating power, right? It's kind of the sad truth of it. But the way that we reimburse those large pharmacies is on an average basis, an aggregate basis. So Walgreens, as an example, what they'd say is, hey, I don't really care what you reimburse me on individual claims, but overall, you need to reimburse me this amount. What that provides legacy PBMs with is the flexibility of saying, okay, for client A, I'm going to do one price, client B another, client C another. And so the PBM is actually the one that now is kind of setting the price of drugs, even though they're not distributing or purchasing drugs at all. They're just setting prices. In that world, the way that they determine, who they give the better deals to is, right, who is up for negotiation at that point in time, right, through this kind of discount-based evaluation process. And as the market pushes pressure on the PBMs to give them better and better discounts, they only can go so far with Walgreens in this case, because Walgreens, right, is saying, hey, on average, you need to stick to this model. Well, with independent pharmacies, that average reimbursement doesn't really exist. And so what they then do is that sadly trickles over to say, okay, well, I only can go so deep on Walgreens. I'm going to have to give independents less so that average number I'm providing to the employer is low enough for me to be competitive. And so it's kind of this trickle-down effect where they continue to get hurt. What needs to happen, and what's sad with kind of the state of independent pharmacies, me being a pharmacist, independent pharmacies are kind of near and dear to my heart. But we kind of did it to ourselves when we were kind of willing to move away from the initial model that was set up as reimburse me for the dispensing that I'm doing the work for, and then for the cost of the drug. Over time, that got kind of conflated, and today it's kind of a joke. The dispensing fees that PBMs typically give pharmacies is less than $1 per prescription, right? Like, it's not even a dispensing fee, right? What we need to do is move back to a model where they're getting dispensed for the work they're doing, independent of the cost of the drug. And that's something that we've been working on over the last couple of years, is really recontracting our entire pharmacy network so that we're reimbursing, the work that's done, that's going to be a much higher dispensing fee than what's in the market, and then a lower ingredient cost because the pharmacies are saying, okay, this is what we're actually buying the drugs for, and we'll take a reimbursement on that.
Got it. So I know, as I just sort of mentioned, that we saw more independent, more community pharmacies over time, and I think people generally do like to go into them, but there's not nearly as many around. Clearly, part of the trend toward, away from community pharmacies has been just by bigger companies doing M&A. But what else is driving that trend? I mean, how much has the kind of PBM activity had an impact?
Yeah, I definitely think there's a number of areas of impact from the bigger, larger PBMs, right? When you look at the pharmacy benefit market in general, about 85% of it's controlled by these big three players, Optum, CVS, and Express Scripts. All of them own their own pharmacies, right? And so their incentives are to drive volume to their pharmacies. And so, and this even happened when I was working in the retail pharmacy side as well for a independent grocery chain. It wasn't uncommon for a patient to come in and, them having been a patient with us for years, and then they switch employers, and with their current employer, there's a mandatory mail order set up, right? Where then they can get, one more fill, and then they're forced to move to mail order. And so as this is continuing to occur, I think that's, pulling scripts out of the independent pharmacies, which is hurting them on one end. And then on the other end, the reimbursement that I was talking about is making it so even if they can keep the patients, they're not making any money on the prescriptions to make it worth even staying. And this has become, further exacerbated with the rise of GLP-1s as an example. Because again, back to pharmacists kind of hurting ourselves. One, we made the decision to walk away from dispensing fees as we were negotiating with PBMs years ago. And then the other kind of mistake that we made is we became okay with kind of what's called cross-subsidization, meaning I'm okay losing money on a couple individual branded medications because I'm making it up on generic medications. Well, as that generic kind of boom is somewhat gone away, when you have a scenario like GLP-1s where just the branded volume dramatically increases, you've now just thrown off the cost structure for a pharmacy, right? Where they're now dispensing, way too many claims that they lose money on versus the generics where they're making money.
Got it. So, you could just say, well, they lost out, too bad. I'll just go to, take your name brand chain store. Is that how we should look at it? Or, what's lost when an independent pharmacy shuts down?
Yeah, I think, a couple of things. I think one, within especially rural areas across the country, right? You're now getting or creating these, what we call pharmacy deserts, where there's just not enough pharmacies to service the patients that are there, which is a problem. So I think it's just a geographical reach issue that becomes an issue as these pharmacies close down. But then I think the second piece that's even more important is the level of service and even clinical care that's provided by these independent pharmacies. It's safe to say there's not one patient, right, that's going to these pharmacies that feels like they have bad service there. Whereas if you were to talk to somebody that uses their local, big chain pharmacy, typically they complain about, the amount of time they have to wait in line and the, just bad level of service that exists and so on and so forth. And so I do think they're an important part of, at least from our perspective as a pharmacy benefit manager, they're an extremely important part of our go forward strategy in terms of we need them just as much as, maybe they need us to get fair reimbursement. And so we've continued to work really across the country with independent pharmacies on making sure they're getting a fair reimbursement and even looking at creative ways where we can potentially provide them more reimbursement for the clinical services that they provide to help better manage the patients that we're serving.
So we've talked about these, legacy, big three, PBMs, big health, and you describe what you do as a modern approach. What makes it modern compared with the legacy model?
Yeah, there's a few pieces to it. The number one piece is just the foundation of how we think about pharmacy benefits. In terms of, I mentioned the kind of legacy discount-based way of thinking. We very much want to look at, from an employer perspective, pharmacy benefits from what we call a cost-based lens. Meaning, if I'm an employer, I don't really care about discounts because that doesn't correlate to what I pay. What I care about is, how much am I paying every month to my pharmacy benefit manager for the cost of drugs, right? And what that does is by focusing on the cost and the net cost of medications, it changes from a pharmacy benefit manager your approach into how you're managing spend, right? Now I'm not necessarily focused on, which medication is going to give me the biggest rebate, that'll give me the biggest discount so that I can meet my contractual obligations to my client. It's, what is really the best overall drug from a net cost perspective that meets the clinical standards that need to be out there to help the patient manage whatever they're treating. So the first piece of it is that cost-based approach to managing spend. The other piece that I think is fundamentally different is because we don't have any, misaligned incentives. We don't own any pharmacies, or we don't own a drug manufacturer or a rebate GPO. We're kind of agnostic to where the claims go. And so what that's allowed us to do is to create what we call a drug pathways engine, where there's really kind of three main levers that you can use to control costs. There's drug source, meaning where's the medication coming from, which pharmacy is dispensing it. There's drug selection, which is, which drug are they using? And then there's what we call kind of cost modifiers, or the drug cost. And are there, alternative ways to help lower costs for patients, like using coupon cards to help with their out-of-pocket expense. So any of those kind of three levers, we've created algorithms as a claim comes into our system to be able to identify, okay, what is the best pathway? And it can be a combination of those three things for a medication. And then we leverage our team of patient advocates to kind of effectuate those pathways and help patients along their medication journey. So drug pathways are an important part of it. And I think the other piece that's hugely important, that is often lost on just the pharmacy benefit space because it's so confusing and complex, is this idea or concept of platform pricing, meaning that, as I was mentioning before, when we reimburse a pharmacy, we reimburse them in aggregate. And so we kind of have the ability to control drug pricing. And what most PBMs do, even pass-through transparent PBMs do, is they'll set different prices for different clients based on size or scale or any kind of type of scenario. What we actually have done and made this kind of fundamental decision from the beginning is that we have one price for every client, meaning it's simple. We've removed the complexity, and whether you're a employer with 20 employees on your plan or an employer with 100,000 employees on your plan, the price of lisinopril is going to be the same at CVS Pharmacy on the same day for that patient. It's not going to vary by our clients. So what that helps with is two things. It helps create consistency across the board. It also helps with pharmacies as well because they know the exact reimbursement that they're going to get on medication from SmithRx.
So part of this, it sounds like there's an approach toward transparency and aligning incentives. Is that an important part of your business?
Yeah, absolutely. I think there's transparency and aligned incentives. And what that really comes down to is this concept that's becoming more and more important now, as I mentioned the lawsuits that are coming about, but what we call fiduciary alignment, right? If I'm an employer and I'm providing benefits to my employees, I have what's called a fiduciary responsibility, meaning that I need to be, responsible for the employee benefit funds that I'm managing. I need to be prudent in how I'm using those funds. And we feel very strongly that the legacy way of, managing pharmacy benefits, or like you mentioned in the beginning, lack of managing pharmacy benefits, really puts these employers at risk from their kind of fiduciary responsibilities. And so transparency is the start of it, but it's really going a step further and saying, everything that we do can help protect you as an employer because we are fiduciarily aligned with your strategies and making sure that you're managing the benefits appropriately.
There's been a lot of discussion about PBMs and some of the challenges and contradictions over the years, and yet it's still the big three. And although there are, as you mentioned, a lot of other PBMs out there, they haven't necessarily gained that much market share, despite putting out a pretty good value proposition. So I guess the question is whether employers and payers are ready to make a shift. What sort of barriers, do you encounter? So we don't have like the big four, or you didn't kick SmithRx, didn't kick out one of the big three. Yeah. What's happening in terms of, traction and what barriers are still remaining?
Yeah, it's been super interesting, and there's been a lot of movement really within the last 18 months around this topic. I've been in the pharmacy benefit industry for a number of years. And when I first started, I worked at a pass-through transparent PBM that had, kind of a similar ethos to SmithRx. And I always joke that we were probably 10 years too soon in selling transparency and pass-through at the time because, pharmacy was maybe 10% of overall healthcare spend, and it just wasn't a focus of employers. And so as we're, shouting from the rooftops, hey, these are the games that are happening and you're getting taken advantage of, nobody really cared. Fast forward, though, to where we are today, and I mentioned the lawsuits a couple of times. You also have, the New York Times and the Wall Street Journal publishing articles over the last couple of years and agreeing that pharmacy benefits is broken, and they don't agree on anything. And so there's just a lot more excitement and I think renewed focus around pharmacy benefits. And you have, every state is trying to do their own legislation to combat and fight against the games that are being played by the pharmacy benefit managers. But what's even more interesting with this, I think, is what we're finally seeing is with all of this noise within the ecosystem, is employers are starting to realize that just kind of renewing and staying with your, the big three PBMs isn't necessarily the IBM safe solution that existed before. We used to always joke that, large enterprise employers never moved because, nobody was fired for picking IBM, and the, total rewards leader didn't want to put their neck out on the line and using kind of an unknown player in the space. But what we've seen over the last couple of years is a number of prominent employers have made the switch and decided to come to, whether it's SmithRx or some of the other kind of big players that are in the space. And so we're starting to see that movement, and proof points are starting to exist in the market. And so I think we're really just at the precipice of seeing this change and this evolution. To answer your question of why it hasn't happened before, what's interesting is there's a number of misaligned incentives that exist. We talk a lot about kind of the PBMs misaligned incentives, but there's that exists as well within the kind of benefit consultant space. So as I was talking about before, typically an employer hires a benefit manager or a benefit consultant to help them craft and put together their benefits. Well, it's sad, but true reality is there's a lot of kind of backdoor payments and deals that the legacy PBMs provide to these benefit consultants that gives them incentives to choose kind of the IBM solutions of old. And so it's a lot of upfront education on our side and trying to articulate that our value proposition is different, and that you need to look at us differently, and that the spreadsheet that's being used and the payments that occur are something that you need to ask questions about. But what we're finding, like I said, is employers are really starting to dive in and dig in, whereas before they were just kind of taking what they were told as truths.
You mentioned that from a maybe independent pharmacy standpoint, they, or including yourself in that, they made a mistake in accepting certain ways of doing business that became entrenched. Now that there's more of a realization, and you mentioned GLP-1s with all the branded products there, that that's not a stable equilibrium for them. Are you seeing the community pharmacies try to take a little more of an active role, and they're somehow helping with this evolution as well?
Yeah, absolutely. And we're seeing it in two different ways. So one is like I mentioned, the state level interest in creating legislation to manage pharmacy benefit managers and to really prevent a lot of the games that are happening from the legacy PBMs. The vast majority of that, to be honest, is driven by independent community pharmacists that are within their state, that are really loud and vocal about the games and problems. And so most of the legislation we're seeing is targeted towards fair reimbursement or no mandatory mail order and all of the issues that they're running into as pharmacy owners. But what we're also seeing is becoming more and more common as well is independent pharmacy owners reaching out to us as well and saying, hey, I know a lot of the business owners in my community. I don't really understand how pharmacy benefits are picked and chosen, and I don't get what benefit brokers do, but can you help me? Because I've got the ear of the CEO or the CFO of these prominent employers in my town, and I'd love to educate them. Because if I can get them to make a switch to a modern PBM, then that means that I'm going to stay in business because I'm providing prescriptions to all of their employees. And so we are seeing this kind of groundswell evolution that's super exciting, and it's at least for me very satisfying to be able to know that we're helping keep a pharmacy in business, and we're helping these small employers save as well, which we didn't necessarily dive into and talk about. But the savings that can come from making a switch and kind of removing that fat that exists within the pharmacy benefit ecosystem is meaningful, and it can provide meaningful value back to these employers that can mean hiring more people or providing bonuses to their employees or keeping their premiums low. And so it's really awesome to be able to be a part of this, movement and helping employers really, stay strong across the country.
Well, we didn't dive into that. You're right. But let's talk about it a little bit. You were saying before when pharmacy costs were just a small part of healthcare costs and you're just saving a percentage of that, people would sort of look away. Now it's more, what does it break down to either on a dollar per employee or what a typical company could have? What's the difference to their economics of going the modern path versus the legacy path?
Yeah. So what we see now, it's not uncommon for pharmacy spend to be 30 to 40% of overall healthcare spend. And so it's, you look over just the last 10 years, that increase that existed, and it's astonishing. And much of that is coming from specialty drugs. And now GLP-1s have been, obviously a huge impact on the budgets of these employers. But what we see overall, if you look at the data, and there's a number of public reports that are out there, Milliman Medical Index is one that's publicly published that shows the average. They look at it on a per member per year or per member per month basis, but spend on prescription drugs. And the poll that they do is largely looking at legacy PBMs that exist in the market. And what we're finding with them is it's typically around $120 to $130 per member per month that they're spending on pharmacy. If you look at pass-through PBMs, so these would be, fellow good guy PBMs that are, charging the employer what they're paying the pharmacy. Again, there's games that can be played there, like I mentioned before, but they're typically around $105 to $110 per member per month. And so you see, just by kind of removing the fat, that spread pricing that exists in that layer, and passing through all the rebate dollars that they're getting from manufacturers, there's a significant amount of savings that can exist there just from switching business models. And then if you take it a step further and you look at pharmacy benefit managers, much like SmithRx, that are actively managing pharmacy spend and, like I mentioned, really executing and pulling patients through these different drug pathways, you can actually go even further. So our average per member per month spend this year is around $85 per member per month. And so you see an additional, like I said, $15 to $20 per member in pharmacy spend that can be lowered by getting patients to the right place and on the right medication.
One of the things you've hinted at a little bit is the incentives even within like an employer. And so they may be receiving, although of course all this is funded by them paying for the drugs, they may be receiving what looks to them like a revenue in terms of a rebate stream. And, if they start to negotiate and they say, well, you're going to lose this revenue that you're using, they may have a certain target or certain things that it's used for. And sometimes that can actually inhibit a company from negotiating or wanting to get, lower overall net payments because they've got this revenue stream coming in. Am I making that up, or is that in fact the case?
Well, it's interesting because that's the, historically that's been the conversation is the, drug prices have continued to increase and rebates have gone up in value. The kind of typical narrative of the pharmacy benefit managers is like, hey, these employers really like rebates. And so they're, we want to give them their money back, and they're fine with drug costs going up because their rebates are going up as well. I think we've gotten to a tipping point though. So, because what we're finding is we talk to employers across the country, and we have over 4,500 clients today across, varying different sizes and, in every state across the country. And what we're finding is with a lot of these medications, I mean, Humira is a great example where the list price of Humira is over $100,000 now a year for a patient to be on the medication. The rebate on that drug is $50,000 to $60,000. And so what you're finding is, that would be great to get that, but then it becomes a cash flow issue, right? And you think about the net present value of money. And if I'm a CFO and a PBM presents to me, hey, instead of paying $7,000 per fill up front and getting a huge check 6 months later, you could actually just pay $700 and get a medication through Mark Cuban's cost plus drug. It does the exact same thing. Which one would you want to do? 10 times out of 10, the CFO says, I want the savings up front, right? I want money now. Whereas historically, I think maybe it's because the rebates weren't as large or as impactful. I do think that narrative existed. I don't think that exists anymore. Like, employers are looking for, they want to spend less, and it's hard to see that you're spending less when you're waiting for rebates that may or may not come.
You mentioned legislation going on at the state level. Is there like a template that's being used in a lot of places, or are there like particular couple of elements of these laws that you endorse or find that are most impactful?
Yeah, it's been fascinating. The federal level, we've been actively involved. We're part of a coalition called Transparency RX, and it's a bunch of fellow, good guy pharmacy benefit managers that are trying to provide kind of a counter view to the legacy PBMs. And it's been fascinating to have these conversations up in Washington and on the Hill about really educating them about the games and what's going on. And there's a great interest in understanding and wanting, to find a solution to this. I think, as we often find, right, in Washington, nothing moves fast. And so there's been a handful of proposed legislative items that have kind of come and failed and still kind of moving, and maybe eventually something happens there. But the states, as you mentioned, have been very active and said, hey, we're not waiting for Washington. We're going to do our own thing. I think one of the challenges for us that we're finding is a lot of these individual state pieces are well-intentioned, and I can understand and appreciate where they're coming from in terms of, hey, these are the games. We need to, kind of essentially stop the games from happening. But what's happening with a lot of them is they're actually becoming very administratively burdensome for us as a small company that's trying to make change. And so one of the pieces that we're fearful of is, in the interest of, stopping the big three from doing their games, they may actually inhibit competition, because it could be where it's like, hey, we can't afford the fees or the oversight or like the work that's required to provide all the data and reporting for you as the state to try to prevent these games when we're not even doing the games. And we're, more than happy to share everything with you, but it's a lot of work and it's, expensive for us to do that. So that's one of my fears as I see these coming about. There's obviously the Arkansas legislation is something that's got a lot of excitement, Florida as well, and kind of the way they're going about things. And I think we're seeing those kind of service templates and how to kind of manage pharmacy benefit managers. But again, it's for us, we need to figure out if we can find a balance where it's, hey, this gets at your intention, but it still allows us to operate and be competitive within your state.
Well, sometimes people think that the big companies don't want regulation, but it's a real barrier to entry. And ironically, if you put enough legislation and hoops and hurdles and make it expensive enough to comply, it will tend to reinforce the oligopoly as opposed to opening up the market. So absolutely.
I mean, we talk internally all the time that, had we tried to start SmithRx today, I don't know that we could have got it off the ground. Due to, being licensed in all 50 states and the cost and the overhead to be able to do that is just, it's a very different world than it was 10 years ago.
Okay, so if SmithRx and the other folks that you've characterized as the good guys succeed, how is it going to be different for patients, for employers, for especially independent pharmacies?
I think what ends up happening, right, in this world is, you see a place where everybody exists kind of fairly and equitably, right? Pharmacies are reimbursed for the work that they're doing. I still think there's some work to do on, and I understand it, but the inherent distrust that pharmacies have on saying, this is what I'm actually buying the drug for, because they're scared that once we have that information, then we're going to reimburse them less. And so there's a lot of, I think, trust gaining to be built in saying, hey, look, we're going to reimburse you a fair dispensing fee for the work that you do. We recognize that, it's not just, throwing some pills in a bottle and kind of sending it across the aisle. Like there's actual clinical rigor that exists here, and we want to reimburse you fairly for that. But on the flip side, we also don't want to overpay you for the medications you're buying. And so in a world where we succeed, I think pharmacies continue to thrive and, have viable businesses. They're not going to be, making money hand over fist on every medication, but they're going to be reimbursed fairly, right? It's going to be a business that can stay and exist. On the patient side, I think similarly, medications cost money. Drug manufacturers put in a lot of upfront dollars and research to bring drugs to market. And so they should be, again, reimbursed fairly for the work that's done there. And patients, as a result of kind of lowering the cost, should have equitable out-of-pocket costs. I think in this world as well, by lowering the cost for employers, that employers would be more open and willing to remove some of that cost share that's been pushed onto patients, right? There was this kind of movement with HSA plans and kind of the high deductible craze of, hey, if we put all the cost share on the patients and give them a debit card, they'll make wise decisions. I don't know that that's necessarily played out because of the complexity that exists within pharmacy benefits, right? If I said, hey, David, here's 5 ways to get this medication, you understand the space and you probably still have a hard time saying, okay, well, how do I get, option A to work, right? And so I think there's a world where employers are willing to remove some of that cost share, right? And take on that burden if patients are able to make, wise choices and are directed down that kind of lowest cost pathway.
Terrific. Well, that's it for another episode of CareTalk Executive Features. My guest today has been Dr. Alan Pannier from SmithRx. He's been helping us understand the pharmacy benefit landscape and where it's headed for a modern era. I'm David Williams, president of Health Business Group. If you like what you heard, please subscribe on your favorite podcast platform. Thank you, Alan.
Thanks, David. Appreciate the time.